Lovely to see everyone today. The first thing I always do when I come up here is to see if I can see over the podium. So I can, so it's going to be a good morning for me. I'd like to thank the Capital District Health Authority. I'd like to thank Pride Health, and I'd like to thank today Sharon and Lynn and Sandy for inviting me to come to the workshop today. Well, it's not a workshop, to the presentation today, and for Jim for doing all the arrangements to get me here. So thank you. I do a lot of teaching. My background is in education, and so it's always nice to come and do presentations. And Jim was talking, and other people were talking today about Stonewall and about coming out and stories like this. And when I try to tell these stories to my medical students, they're like, "This is boring. We know all this. We don't want to hear about LGBT stuff anymore. You're past, say, this is boring, Dr. Knudson, let's talk about something else." So, and it's interesting because we've had this, we teach in DPAS, Doctor, Patient, and Society in the medical school. So we always try to change the curriculum. And so we've had, LGB criteria and curriculum, and the medical students are not interested because they said, yes, this is part of our lives, etc. We don't see that necessarily carries on in terms of the indicators of health and how people are treated in the community. But what the medical students want to learn about now is transgender health and transgender health care. So where we are in terms of medical education is in terms of transgender health, it's like where people were in medical education 25 years ago when we look at LGBT health. So this morning I want to talk about what are the indicators and what is the data around transgender health. And Sibel just had a really nice point this morning about people aren't going to listen to you unless you have the data. I work a lot in policy, and for years and years, there was no data in terms of transgender health. It was all, first all the health data came out of LGB, and then people assumed, well, LGB, let's put T in there, and there must be trans people in that category. And then what they did is they started doing research LBTQI, and they lumped everybody together. And now, for the first time, there's been a large study done, and I'll highlight that in my talk today, just in terms of transgender people. So this is a landmark study, and this will help drive policy in North America. So today I'm going to talk about some terminology, some definitions of terms, obstacles to overcome, some case presentations, and an area in terms of how do we break down barriers. So in terms of sexual orientation, this is people's sexual object choice. So everybody knows this term in here, and what's people's sexual identity, and also how do you express that. And I think Jim was going to get people to put their hands up early. But what people sometimes don't get, so these are very commonly used terms, but then when we get into gender, people that don't work in or in the kind of cultural competency world or spectrum, or if they work outside of kind of GLBTQ healthcare, they don't get the difference between sex and gender. And so when you're looking at gender identity, it's one's internal self. Do you feel male inside? Do you feel female inside? Do you feel transgender inside? And then there's gender expression, and that is how do you present to the world. And I always think that this is really interesting in that when my son was about 4 or 5, small kids, how we file things is, okay, that person's a man, that person's a woman, that person's a man, that person's a woman, and if a person doesn't quite fit, you kind of keep cueing on that person over and over again because it's not filing in your head. And so we automatically do this because it's how we learn to identify people as young children and going farther. So when we look at oppression and we look at stigma, overall, trans men, or people that are born female and transition to male, do a lot better in society because they pass very well, versus people that are born men and transition to women because of their features. They might be really tall, really big boned. They don't necessarily pass as well. So it has healthcare indicators. So cross-dressers. So cross-dressers are people that dress in clothes opposite to their assigned sex. And it's interesting because people think that this is pathological. It's not. This is what people are choosing to do. This is part of their lives. But there sometimes people are really distressed by this. And that's when it becomes a distress-based kind of disorder, and like transvestic fetishism. But cross-dressers, no, lots of people cross-dress, 1% to 6% of the population. And then we go more into definitions around gender. So what I find fascinating about working in this field is that the definitions are constantly changing. And they're not only changing, within the countries, they're changing globally. And what one word means in North America means something different in Europe and means something different in Asia. So even within Canada, when you translate a person that has gender identity disorder or gender dysphoria from English to French, it doesn't translate. In French, the word for that is transsexual. And so they're like, what are you talking about, people with gender dysphoria? We only have transsexuals. So, and also, that's the same in Europe. So in terms of people that have gender dysphoria and they want to maybe take hormones and surgery, they are they are identified as transsexuals, whereas we don't say that really here because it is seen as a negative term by some transgender people, and yet there's a group of transsexual people that are reclaiming this and are very vocal about saying, no, we are transsexuals. It's almost like reclaiming words like queer and things like that. In terms of words that we're using today or language, trans men, we used to say F to Ms, or female to male transsexuals. Now we use trans men, and trans women. And in terms of transgender, in North America, it means it's an umbrella term encompassing all people that are gender variant. In Europe, it means something totally different. In Europe, it means people that choose to live in the middle. So again, the language is depending on where you live, how you're located, and how you see things in what political way. Gender dysphoria is the distress caused by your incongruence between your natal sex, or the anatomic sex that you were born, and your gender identity. So most people are what we say gender congruent. So I was born female, I feel feminine, I have a female gender identity. So that's congruent for me. Whereas I could be born female and have a male gender identity and feel masculine, and then I would would want to change that, and I would have gender dysphoria. So, how many people in the room know what the DSM, or the Diagnostical Statistical Manual, is? Put your hand up. Okay, so about 85% of people. So for the people that don't know, what it is it's a manual that's used in mental health that's put out by the American Psychiatric Association, and it codes people in terms of mental health disorders. And how we code right now in terms of if a person has gender dysphoria, and wants to maybe change and have a real life experience and live in their chosen gender role, and they have a lot of dysphoria, they may fit the criteria for gender identity disorder. And so there's a lot of controversy around that, because in order for a person to receive care, have access to care, they have to have this diagnosis. So it's kind of a slippery slope. So it's pathologizing people in terms of their identity. But on the other hand, if we don't give them that diagnosis, they don't have the access to care. I'll talk a bit more about that later. So in terms of obstacles to overcome, what types of obstacles do trans people have to overcome? And these are the two studies that they're actually American-based studies that I'm going to quote today. And the one on the left is Advancing Gender Equality by the MAP Project. And the one on the right is the landmark study that just came out last year. And before I was coming up here to talk, I was talking to Jamie Grant, and she's in India right now, and she sends her greetings to you. And she's actually, her family is from Nova Scotia, and she's the lead author at Injustice of Every Turn, and that came from the task force. And the task force is an organization in the United States that helps with driving gay and lesbian, bisexual, transgender policy. So they did a study last year, or the last couple of years, and it's based on 7,000 respondents, transgender respondents over the U.S. So it's a very representative sample, and it's the only sample that's available of that scale in North America, and Europe for that matter, that looks at what are the health obstacles and what is going on in healthcare with respect to transgender people. You know how you were talking earlier about this distress and balance earlier, in terms of this is going to be very distressing. So, but the second part hopefully will be balancing, to talk about what we're doing to try to help overcome these obstacles. But I have to tell you that these statistics, like Sibel's statistics, are very distressing. So this is from Susan Stryker's work, and it looks at obstacles that trans people must overcome. And she did this model in terms of American life, and I just put this in life in general, all the different spheres. And there's physical and mental health, safety and physical security, employment and self-sufficiency, and legal documentation and relationships. And many people in this room know, in terms of indicators of health, and what we've talked about this morning, all the speakers so far, is, you know, if you don't have employment and self-sufficiency, that affects your physical and mental health. And if you don't have safety and physical security, again, that affects your physical and mental health. So all of these circles are interrelated. So let's look at employment and self-sufficiency. So what are the employment obstacles? Well, there's job discrimination, unemployment, poverty, and what we see, unfortunately, a lot of in the trans population, for people that have all these obstacles and barriers to care, is there are people that are in sex trade work as a livelihood for last resort. So what are the economic indicators? Well, trans people in the U.S. have doubled the rate of unemployment. And what I really, really like about this study, and what Sibel touched on just a few minutes ago, is that in the studies, they were never cross-tabbed by race. And this one is cross-tabbed by race. So it makes it even more powerful. So if you are a person of color and transgendered, 4 times the rate of unemployment. So look at the harassment, and in terms of this. So if you're looking at the harassment, 90% harassment at work. So huge numbers. And 47% adverse job outcomes, and it goes on and on. So I think it's interesting when you look at the bottom, a lot of people had chosen to hide their gender transition or delay it. And it makes it even more difficult because for people that are transitioning, one of the indicators in terms of access to health care is that you have to, and to qualify for surgery, sex reassignment surgery, is that you have to live in that chosen gender role. So here we are, there's 71% hiding their gender role or delaying it and not having access to care. So if you look at this, this is a nice statistic in that even though they transgendered from one to the other, in terms of transgendering from one gender to the other, they felt more comfortable at work. But unfortunately, 16% said that they had to work in the underground economy, whether that's selling drugs or working in the sex trade. So if they'd lost a job due to the bias, due to the transgender bias, they had 4 times the rate of homelessness, and we'll see why, because they were refused from going to shelters or from other kinds of levels of care. And they've got double the HIV infection rate. And also, if you're working in the underground economy, that's, again, leading to that, you're more likely to have those negative indicators like HIV. So if the people were unemployed when they completed the survey, again, look at how high these rates are. Double the rates working, doing sex trade or selling drugs, double the rate of homelessness, double the HIV rate, and double the rate in terms of alcohol and drug problems. So very sobering statistics. So let's look at, looking at that in terms of, we had the employment and self-sufficiency. We've seen that that the trans people were very negatively affected even if they had a job or didn't have a job, and also about how awful the rate of homelessness was. So let's go to another sphere, legal documentations and relationships. So we're lucky in Canada in that same-sex marriages are not a problem in Canada. But years before this, I know I saw lots of people that would have to be divorced if they were going to have, as a result of the sex change, because there was no same-sex marriage bill. Well, this is the case in the States in terms of if there's no same-sex marriage bill, the people have to get divorced when they have a legal sex change. And there's also lack of appropriate identity documents. Well, it depends on what's going on in Canada. If we take this to a Canadian focus, Passport Canada, depending on who's working at that time and things like that, will issue passport changes in terms of if you have the vital statistics form to back that up. And the vital statistics forms in Canada, it depends. Every province is different on what they will do in terms of changing your gender designation. But let's look at what happened to what the trans people reported across the United States. So for people that have transitioned, only 21% of them have been able to update their identifications, and then 33% didn't update any of their records. Part of that had to do, I think, that there's, problems with access to health care in the States, and if they would change their identities, would that affect their access to what kind of services they would receive? And so in that, when you look at that bar graph, only 41% of people live without, 41% people live without any matching ID. So what are the safety obstacles that people face? There's violence and abuse. There's homelessness, and we've seen that the homelessness rate was double. Unsafe public restrooms, unsafe schools, unsafe prisons, jails, and juvenile homes. So if you look at public accommodations, so such as hotels, restaurants, government agencies, 53% reported to be verbally abused or disrespected. And then when you looked at in terms of a helping professional, 22% were denied equal treatment by government agencies, 29% in terms of police harassment in the US, and 12% have been denied equal treatment by judges or court officials. In this, when you look at this, the survey, it's available online and it's free. I thought that the statistics that was very scary to me being a physician is that 2% of the respondents reported being physically attacked in a doctor's office. So let's return back to housing discrimination and homelessness. So 19% being refused for a home or apartment based on their transgender status, 11% evicted, and when you look at the people that were homeless at one point, they said that 55% of them were harassed by the shelter staff or residents. And staggering 22% reported being sexually assaulted by the residents or staff. So that's huge. That's 1 in 5. So 2% of the staff of the respondents were currently homeless, and compared to the general population, which is 1%. And look at the home ownership, it's half, so 67% versus 32%. Here's a race cross-tabulation looking at, they were denied a home or apartment by race, and look how high it is for, they use the term American Indian in the States, and we use First Nations people, for 47%, so it's very high. And look at multiracial overall, 32%. So there's your cross-tab between race and gender. This is very upsetting. When you look at this, 15% left school because of the harassment, because the harassment was so severe. And the people that had to leave school and that were harassed had worse health outcomes, and that's not surprising. So if you look at that, 78% of people were discriminated against in high school for that gender variance. I'll tell you a personal story that happened yesterday that came across my email. My son goes to a segregated school, in that there's girls in one class and boys in another class, and in terms of after-school activities, they started offering ballet. And so it was interesting because one of the boys in the class wanted to take ballet, and so all the other boys in the class, or some of the other boys in the class, decided that they didn't think this was a good idea, and so they started teasing him. So on one hand, I'm sad to see that that's happening, but on the other hand, I'm glad that I got an email from the teacher and how she handled the situation and what she said to the boys within an hour. So in terms of harassment and discrimination in schools, what are the respondents by income in terms of maltreatment in schools? So this, again, this talks about not only transgender status, but it talks about wealth and income. So we know that in the general if you look at the population, that as you go up in income, there's usually less maltreatment in schools. So if you look at this, that if you're at the 50K mark or 100K in the general population, there's 33, there's no mistreatment in schools, and 21 mistreated in schools. So you can see even as the numbers go up in the schools, there's still mistreatment. And finally, let's look at physical and mental health. So what are the major health barriers or the health obstacles? And this is what I'm going to focus on for the rest of my talk. Deficient and inferior health care, lack of funding for medications, surgeries. And it's interesting that this was, when I looked at that in terms of transferring it to a Canadian model, I thought, oh, maybe that's a problem. Not a problem, but it is. It's a problem because people have to pay for their medications depending on what province they're in. They have to pay for electrolysis if they're transitioning to female. That's $7,000 of electrolysis. Some other provinces pay for surgeries, some don't. Surgeries can cost up to $40,000, $50,000, $60,000. Also, with all these barriers in terms of health care, and Dr. McKenzie talked about this and several other people, is that if you have more of these obstacles in all the 4 areas, you're at higher risk for mental illness and higher risk for self-harm. And you have all the related health problems. So if you look at the healthcare outcomes in this study, look at the refusal to care. It's all about, for me, access to care, and only 19% of the population reported being refused medical care. And then 50% of the patients said, or the respondents said, that, I always go into doctor mode because I see the doctor thing in there, that 50% of 50% of their physicians needed education. So it's kind of sad because the doctors should be able to be educated in that area and providing care. HIV rates, they're astronomical. They're 4 times over the national average. And the rates are even higher among people of color. And in terms of postponed care, a lot of people postpone care because of the discrimination, or they weren't able to afford it. So 20% said that because of the discrimination, and almost half couldn't afford it. And this is the most staggering statistic in the whole study. And I leave this to the last slide before I go on to looking at what we're doing to help the situation. Look at this in terms of the overall sample of these 7,000 people across the U.S., 41% had attempted suicide. That's incredible, and it's very sad and very jarring. And it's not surprising, looking at the numbers, how it goes up depending on what type of employment people were in. So that was the worst statistic. Now it's starting to get better, hopefully. So in terms of when they looked at resilience factors, that was the last part of their study. And we have looked at this in terms of outcome studies for transgender health. It's always the family that is the most important predictor of success in people's transition. So the family acceptance was of greatest importance. So when you looked at this slide, look how having family support impacted the person's experience on all these areas. So if families were accepting of the person's transition, they experienced less homelessness, less incarceration, had to do less sex work, less incidents of suicide attempts, less incidents of smoking, and less drug use. So the family is very, very protective. So this is a story that they had in one of the in one of the reports about what are some obstacles to care. So we have Tina, who is a masculine-seeming girl, and she's going to school, and she's quite masculine, and so she's harassed at school by this, and her family doesn't really like the choices that she's making. They think that she should change, and this is something that's a phase, and it's just something that she's just going through, and you hear that theme throughout the day. And so because of this, it affects her school grades. So she has poor school grades, and her family are rejecting her, so she goes and starts couch surfing. And so she moves in with a friend, and then, because she's got the poor grade, she doesn't really have a lot of job prospects after she's graduating. And then she can't, but she wants a transition, but she can't afford the hormones, the sex reassignment surgery, the ID changes. And then she tries to get a job, and she's fired for this because her IDs don't match. And she can't afford to pay the rent at her friend's, so she gets kicked out. And then, so she ends up at the homeless shelter, and she's placed with women, but she's very masculine and masculine appearing, and appearing as male, and they kick her out. So she's out on the streets. She has no job. She has no family support. So what does she turn to? Well, she starts to work in the sex trade, and then she's arrested. And then, unfortunately, she's harassed in jail, and then she starts using drugs in jail. And this is this kind of circular thing of being incarcerated and getting money for drugs and things like this in the addiction circle. And then, unfortunately, she ends up with HIV. She's 25, she's homeless, she has no job, and she's in poor health. So let's look at some of the barriers that we can break down so that people like Tony don't have to experience life like this. And there were barriers in these 4 areas, or the 4 circles that we looked at. So how can we look at all of these areas? Well, we can look at them through advocacy, through litigation in terms of lawsuits that are going on, through services and support throughout the community, through research like the National Transgender Discrimination Survey, and through public education. So if we look at one of the first circles in terms of employment and self-sufficiency, I'm sure many people in the room know about Bill C-389 that's being sponsored by Bill 6A right now. It's made it through the House and is currently in the Senate, and it's waiting to come up for the last reading for final approval. And it's an act to amend the Canadian Rights Act and Criminal Code on gender identity and gender expression. And then this will, because right now it's based on sexual orientation and you cannot discriminate against that, but there's nothing in there in terms of gender identity. So we're really hoping that this will go through, and people from EGAL Canada are big pushers in the area of trying to get this through, and there's been a lot of support in the community for this in community agencies. It's interesting, we're talking about Facebook and things like that. A lot of things on Facebook coming through my email and things in terms of how the public media and the social media is really helping to drive this. Safety and physical security. I think one of the key things that has been instrumental in changing things in larger high schools, I'm not saying in smaller high schools, but in larger high schools in urban area, are these gay-straight alliances. And I think that they've been very helpful in terms of educating the schools, like as in other students in the schools, and also providing a safe haven for people within the school. And we've got LGBTI centers in colleges and universities. So many people that I see that come to me for a surgical assessment said, I didn't really feel safe coming out as transgendered or gay when I was living in my rural area. But when I went to the university, I found, the queer center, and that saved my life. I think they're very, very important vehicles. And the youth projects, like the youth project you have in Halifax, is very, very important and probably the best youth project across the country. And then there's public policy, like this came out not too long ago, Gender Identity in Schools, put out by the Public Health Commission, and that's really important in terms of educating people. Legal documentation and relationships. You can change your sex after completing the vital statistics form in Nova Scotia, and also you don't have problems in terms of you don't have to become divorced or absolve your marriage after you have a sex change, because we have the same-sex marriage bill. The other thing is that in terms of assisted reproduction in Canada, there aren't discriminatory barriers in terms of sexual orientation or gender when you go to, when you are applying to have assisted reproduction. And physical and mental health. These are the last part that I want to talk about, and it has to do more with creating access, and as we go farther down, it's more about creating change on a policy level. So here you have the Capital District Health Authority, and within that you have Pride Health. And Sibel is the director of Pride Health, and she described about her job and what Pride Health does. Also, I'm here because of the Gender and Equity Committee, and also because of Sharon's position within the government, which I think is very important that she mentioned that at the beginning, is that there are very few portfolios like hers around the country. And I think it's really key that you have one here. And I think that it looks very favorably for Nova Scotia. You have a youth project here, which has been very helpful and very instrumental in terms of helping LGBTI youth. And you have the Transgender Health Clinic at the IWK. And what was Sue saying yesterday? They had how many referrals in the last, 12 in the last year. So they're in year 3, I think, and so they've had 3 in the first year, 6 in the second year, 9 in the third year, and 12 in the fourth year of youth, gender variant youth accessing their services. And then we'll talk a bit about the clinical supervisions group, but you have physicians here that are seeing transgender people in family practice, in endocrinology, in psychiatry, and in mental health. Jim's position was a dedicated position in mental health to see people for hormone assessment, so they didn't have to pay privately. And also there's a dedicated psychiatrist that can see people 1 to 2 days per week in terms of if they need other services or other assessments. What we've been doing the last 2 days is starting a clinical supervision group. There was a group that was here already that was started, and this is more in terms of a clinical focus. So what we did in the last 2 days is spend time with people that are clinicians working in the area of transgender health, so that they can do hormone assessments for people, surgery assessments for people, and also have an integrated network of decentralized care of social workers and endocrinologists and family physicians and mental health professionals, so that all of the care is people get good care. They don't have to be in the same office to receive good care, but they have to be, but there has to be a network of professionals within the community. So this is now in place. What are we doing more on a national level? Well, so things have been started in Halifax in the last probably 4 or 5 years and just continue to grow. The access to care continues to grow. And what we did in about 2007 is we started an organization called the Canadian Professional Association for Transgender Health. And Jim here was one of the founding members. And what we did is that we knew everybody across the country of who was working in transgender health, and there was probably about 26 people at that time, and we met at a meeting at the World Professional Association meeting in Chicago in 2007. So we formed a group, and now we have 140 members across the country, and we meet every year in a Canadian city and another year in the WPATH hosting city. So we have a website and a newsletter, but we write a lot of policy and we write a lot of letters in terms of supporting important bills that are coming out, like Bill 6A's bill. And we think as a professional organization, we can have a lot more influence in terms of being banded together rather than health professionals across the country. And this came from WPATH, and WPATH is the World Professional Association for Transgender Health. We have about 500 members, and I send greetings from Dr. Walter Bochting, who is our president. And we have a board of directors and 2 hired staff, and this is at the University of Minnesota. That's where it's housed. And we have a listserv for public members, and we have a biannual conference. It's going to be in Atlanta, and I'll talk a bit more about that. But the 2 things that WPATH does that's important in terms of policy is we publish a standards of care document and a journal, the only journal in the field that talks about transgenderism. So it gives it a voice, it gives us academic base and research so that we can move forward. So the standards of care, we first started in 1979 with the first version of it, and it's a consensus document, and it's about management in terms of psychiatric, psychological, medical, and surgical management, helping people who have gender dysphoria. And the latest version is going to be released in Atlanta. So if you come to WPATH, you'll see the latest release in Atlanta in September, and it's Standards of Care 7. And it's really interesting to see how this field moves along and how it's moving along quickly from Standards of Care 6 to Standards of Care 7, and you'll be seeing that soon in September. And so we met last weekend in Minneapolis, and to do the rough draft that's going to go out. And I think what's interesting about this and how everything is moving is that we have an international advisory group of community members from all over the world. And what's hard about it is that everything kind of has been Western-based, and for us to make it a document that's global makes it very difficult because all of the standards of care and all the practices that have been done have been in the Western world. So it still remains quite a Western document. And then earlier I was talking about the DSM that is coming out of the Diagnostic and Statistical Manual, and you've probably been hearing a lot about this in healthcare. If you work in healthcare, the new manual, or DSM-5, is coming out in 2013. And I think what's interesting about this is that when we look at gender, it used to be called gender identity disorder, there was a big kind of movement within academic culture and within the community culture and within the advocacy culture about this person doesn't have a disorder because of their identity. It's not a gender identity disorder, it's gender incongruence or gender dysphoria. It's not a disorder of their identity. So however this comes out in DSM-5, it's going to be either gender incongruence or gender dysphoria, and it's going to be based on a non-binary model. So people don't have to go from male all the way over to female or female all the way over to male, because as we look in terms of our gender roles, they're kind of, they're spread across the spectrum, but it's more in terms of where they are on that spectrum and kind of consistency across that spectrum, so it's non-binary. And also they're taking it out of the sex and sexuality chapter, because it doesn't have to do with, sexual medicine. So the next project that's coming out is ICD-11, and there's a book published by the WHO, and it's called the International Classification of Disease, and that's coming out soon, in the next 2 or 3 years, and it looks at all the different people, all the different classifications of disease. And so transsexualism is in there as a disease under psychiatry. And so, so the challenge is to take it out of there, like to change the name, if it's going to stay in, take it out of mental health and put it in another location. It's too soon to see where it's going to go. But as soon as you take it out, then it limits access to care globally. So there might be, there's pros and cons to it. So I'd like to invite you to our meeting, our symposium. We have our CPATH meeting on the September 23rd, where we have all the Canadian members. The WPATH pre-course for people that want to learn more about transgender health is on the 24th. Our symposium is the 25th to the 28th, and it's at the Emory Conference Center in Atlanta. And because we want to increase access to care to trans people, so that we have stories like this, better stories. This is Kathy's story. So Kathy was Kevin at age 15 and was a feminine-seeming boy. And he always had feelings about being a girl and that he felt like a girl inside. So he approached the gay straight advisor in his urban school. And then what happened is that he was referred to a therapist that was a specialist in gender. And they talked to his parents, and then started to come out, and then did well in school. She started using feminine pronouns and started going to the LGBTQ center, the queer center at campus, and then starts to undertake a transition with their friends' support. And in this case, the wealth is a factor that helps, because her parents had the money and the access to pay for the medical care. And then she graduated from university, and because of the healthcare policy that was available, it paid for her surgeries. Like, for example, she could have worked for the city of San Francisco, where they pay for surgeries, and then she chose to marry and adopt children. So I want to see more stories like this for transgender people, and the next time that Dr. Grant does her study, that the rates of suicide and attempted suicide are not so high. So I'd like to thank you for inviting me here today, and for allowing me to present and to congratulate you on the work that you're doing in Nova Scotia. Thank you.